So Dr. Jacoby, once you've gotten the results back from the interpreting physician, you have this new information to work with, how does that affect what you do with that patient? I mean, what are the different modalities, the thought processes you can work into a treatment plan for yourself?
Well, when I get the information back from the nerve conduction test, if it is positive, then I know there's a compression neuropathy. What I mean by that is there's compression on the nerve that is causing the pain. If it's negative with the nerve conduction, it doesn't necessarily mean that there isn't a problem. The problem, I like to phase neuropathy into phase 1, 2, 3, 4, and 5. Phase 1 is early neuropathy. Its symptoms are fleeting. They come and they go. That is not best diagnosed with a nerve conduction. Phases 1 and 2 are best diagnosed with epidermal innervation density biopsy, which is a skin biopsy. Phase 3, 4, and 5 are best diagnosed with nerve conduction. So depending what I get in what phase depends on what I'm going to do from a clinical standpoint. And also, I have to link the history, the diagnosis, and the physical exam. And once we have all those things, then we can have a treatment program. And then it's either medicine or surgery or a combination of both.
The question I get from a lot of physicians that I call on out there in the marketplace is, or the comment I get is, I don't need diagnostic testing. The patient says they have pain, numbness, and tingling. I know all I need to know. How would an NCV possibly change things? How would you respond to those people about why it's a good thing to engage in objective testing?
Well, I think before you embark on any type of treatment protocol, it's nice to know, or maybe essential to know, where the cause of the pain is coming from. The upper extremity is fairly well known. The lower extremity is probably less known. The upper extremity, when patients have carpal tunnel, and they have tingling or numbness of the median nerve, it's very common to do a nerve conduction. But it seems to be less common to do it in the lower extremity for tarsal tunnel. But the same things hold true. The same thing that happens to the median nerve or the ulnar nerve or the radial nerve and part of the brachial plexus. There's a term we use, it's called the double crush phenomenon. Mm-hmm. Right. In a clinical setting, a patient may have compression more proximal and more distal, and these summate. In other words, they add together to cause the problem. And we have to locate each one of those anatomical places where this compression is happening and reduce these compressions, if we can, by either surgical or medical modalities, or physical therapy, or change in nutrition. All these things play into the differential diagnosis and the measurement and the treatment of these conditions.
And you've done at least 1,000 of these decompressions yourself.
Well, I've done it, well over 1,000, mainly in the diabetic population, because that's where most of these patients will reside. Now, it sounds counterintuitive that a diabetic would be operated on, but in a sense, it seems silly to maintain a patient on just medications, because the medication works centrally, not peripherally. So these patients are going through phase 1 all the way to phase 5, thinking they're getting better when they're not. There's 100,000 amputations a year in the United States due to this disease. Nerve pain is a serious problem because it shuts off the blood supply to the small vessels. It's not the other way around, but it has to be in the differential diagnosis.
And I have read that of those 100,000 plus amputations every year, somewhere around 40 to 50% of them have never had a diagnostic test.
That's true.
And that's information I think it's worth for the public to know.